Subaba Khair, good morning and welcome to the latest Queen Mary Global Policy Institute Global Seminar devoted to public health in Pakistan and the UK, challenges and ambitions. The Global Policy Institute at Queen Mary University of London was established to help translate brilliant research in all fields into lasting social and policy impact. To this end, it relies on three core principles: mutual learning, dialogue, and impact. These principles are in evidence in the composition of a very eminent panel today, assembling very real expertise across the disciplines in common pursuit of excellence and impact. Our panelists are Mr. Aziz Memon, philanthropist with 2 decades of polio eradication work, trustee of Rotary Foundation, and chairman of the King's Group, and vice president of the English-speaking Union of Pakistan. Professor Uzma Hassan, professor and head of Department of Public Health at the National University of Medical Sciences Institute of Advanced Studies and Research, Rawalpindi. Dr. Aryane Rietsema, senior health specialist, UNICEF, based in Kathmandu. Professor Irene Lee, world-renowned expert in non-melanoma skin cancer, alongside many leadership positions in the UK and overseas, and your host this afternoon. Professor Fiona Walter, Director of the Queen Mary Wolfson Institute of Population Health and a GP, Professor Ranjit Manchanda, Professor at the Wolfson Institute at Queen Mary University of London, and a consultant gynecological oncologist at Barts in the London Hospital, London, and Professor Vicky Bird, Professor of Mental Health Care at Queen Mary, and last but not least, Dr. Wan Ize, Specialty Registrar in Anesthesia and Intensive Care Medicine within the London Deanery. So I'm delighted that you've joined us this morning. Thank you so much for your patience as we wrestled with some technological gremlins. And with that introduction, I will hand over to your host, Professor Irene Lee. Professor Lee, Irene.
Thank you very much, Colin. So welcome, everybody. I am very sorry that there's been a delay, but we have had significant difficulties getting connected this morning. So we're starting rather late, which means that we're going to be short of time, I think, for questions. But if you have any questions, please could you place them in the Q&A session, and we will attempt to answer them afterwards if we don't have time to answer them today. So without ado, I'd like to introduce our first speaker. We're managing this meeting as a dialogue with representation from Pakistan and also from GPI in East London to think about the common ground that we share. And our first speaker is going to talk about public health challenges in Pakistan, Mr. Aziz Memon, who's been introduced to you. Over to you.
Thank you. Thank you, Professor Collins. Pleasure to be with you. And let me start that public health in Pakistan, the challenges and the ambitions. The public health after the 18th Amendment, which was passed 3 years back, has now become a provincial subject, and the provinces are autonomous in dealing with them. So let's start with the first slide. These are, I've shown in this, the epidemiological shift leading to the double burden of disease. We have, if you look at the first graph, which is of 2000, and the second one is of 2019. Now, in the first graph, 2000, you see the communal diseases are 60%, whereas in 2019, the communicable diseases which are infectious, like mother and child, or maybe measles or flu or hepatitis, that have reduced. And the burden of non-communicable diseases like cancer, like diabetes, like Alzheimer, have increased. So it has come to almost half and half and the smaller portion is for the injuries. And this chart, shows that in what areas this diseases imbalance has taken place. Next slide, please. Now, the key challenges in Pakistan or in any other third world countries, they are very similar. Weak governance in health sector, low financial allocation for health, 1% of GDP in public sector, it is too less. If you look at other countries, they go even up to 16%. So 1% is really, really too low. Inadequate access to the universal health coverage and quality of care. Crisis in health workforce. Sometimes they are struggling for the confirmation of their job. Sometimes they are struggling for the increase of their salary. So this continues on daily basis. Frequent health emergencies. We are facing one pandemic. COVID is not leaving us. It is there. And such emergencies do come up. Sometimes there is a measles breakout. Sometimes there is a meningitis. Sometimes there is dengue. So these are off and on coming and disturbing us. Addressing determinants of health. Now, this is addressing the determinants of health is very important. Harnessing research and innovation. Without research, without innovation, we cannot move forward. Like after 10 years of research, we got a OPV, that is IPV2, which is now focusing on the polio-derived cases. I won't go into details about polio, maybe some other time. Next slide. These are the public healthcare delivery system prevailing in our part in each of the provinces and showing the number of hospitals, the RSCs, the MCH, and the definition of each one of them is here. And those who are from Pakistan, to them, these terminologies and these numbers are very familiar. The LHWs, lady health workers, play a very important role in the primary health care. A baby is born and the routine immunization starts and goes on till 22 months. This is a very, very important thing. So, this lady health workers are responsible for giving the pentavalent or hexavalent. And now, even the polio shot is included in the pentavalent and is called hexavalent. Next, please. So next, please. Now, these are some of the universal UHCs, and this shows the universal health coverage numbers, the target for 2030, where we would be in 2023, and where we are today. So, if we are today at 40% of 40 is too low, and we need to increase this to 55, and then the target would be in 2030 to 65%. Now, additional people having access to UHC by 2023 would be 46 million population of us. So this is a very important number. Next, please. Translating strategic priorities into action. Enhance financing for health. Expand health service based on UHC benefit package. Ensure availability of health workforce with proper skill mix. Tackle nutrition crisis. Now, nutrition crisis also in this part, malnutrition, stunted growth are, too much. I have formed a trust for malnutrition, and we are helping so many babies. And now we have gone a step backward, taking care of the pregnant mothers also. So we are giving sachets to just not children who are undernourished or who have the issue of stunted growth, but to mothers also. So this is, UNICEF also supports this program in a big way. And we are doing it with 5 hospitals. We need to increase more hospitals, improve quality of service, very important, strengthen internal sector collaboration, promote culture of evidence-based decision making. Now, this is lacking, We took a very long time to get rid of a simple disease like polio, which could be done with the OPV drops, just because the beliefs and the thoughts and the words of the religious leaders always hinted. But I'm glad to share with you, and I want to congratulate the Prime Minister of Pakistan, the people of Pakistan, our partners, WHO, UNICEF, Bill Melinda Gates Foundation, and each and every Rotarian in Pakistan and abroad, that tomorrow we would be completing 1 year without a polio case. So this is a remarkable achievement for the health sector of Pakistan, for the primary health sector of Pakistan, and this will open the doors to further strengthen and improve our global health alliance. We have to work on the routine immunization, which is very important. Now, for example, when we were getting the wild polio cases, 86% of those cases showed zero routine. Now, zero routine means the child has not been given any routine immunization. So this was a clear-cut indicator that we need to strengthen our routine immunization and improve the primary healthcare. I think I have finished my time, and if there are any questions on email or till I'm around, I would be too glad to take them. Thank you very much.
Thank you very much, Mr. Menon. So the next talk is to set the scene in East London, and I'm going to show a couple of slides. As you know, Queen Mary University of London and the Global Policy Institute is in the heart of East London in an area called Tower Hamlets. And this is a very distinctive area because it is an area of significant health deprivation. And the population is characteristically young, growing and diverse, with a high percentage of non-white occupants, particularly from Bangladesh, with a high population growth and a high proportion of young people and young people in education, and particularly high areas of socioeconomic deprivation in the UK, so that 78% of the population live in the most deprived areas with high levels of child poverty, unemployment, and significantly for us as a higher education institute, low levels of educational attainment. And these significant health inequalities result from this socioeconomic deprivation. 3 major killers in Tower Hamlets are cancer, cardiovascular disease, and chronic respiratory disease. Next slide, please. So the public health challenges in Tower Hamlets are very significant throughout life, not only in infant mortality, but in life expectancy. And in terms of infectious disease, has had a high prevalence of tuberculosis for some years. But one of the issues that we would perhaps like to address in the talks going forward are the impact of the COVID pandemic and the uptake of COVID vaccination. But we also have a very high level of chronic non-communicable disease, with significant problems with obesity in childhood, mortality, as I said, from cancer, cardiovascular disease, and pulmonary disease. And we have high levels of mental health. So we'll be touching on these in the talks that follow. Queen Mary University of London is therefore really very significantly committed to an agenda of equality, diversity and inclusion and aims to be the most diverse university. Educationally, we are supporting local education engagement and developing new programs, particularly such as apprenticeship programs and an Institute of Technology. And our research is committed to addressing health inequalities, particularly in cardiovascular disease, cancer, population research, in primary care and public health, as you will hear from Professor Walters a little bit later. So our Global Policy Institute has significant interest in health inequalities, particularly in the fields of resilience, recovery, and planetary health. Okay, that's the end of my slides. Thank you very much. So the first issue that we're going to discuss is the COVID-19 pandemic, and our first part of the dialogue is coming from Pakistan. Dr. Arjan Risma is going to tell us about the situation in Pakistan.
Assalamu alaikum, everyone, and good morning or good afternoon. I am based in the regional UNICEF office for South Asia in Kathmandu, but I worked in the UNICEF Pakistan country office till July last year. So I know the situation from my time in the country. Can I have the next slide? Aziz has indicated the situation of the health system in Pakistan. My slides will be complementary. So a few words on the impact of COVID-19 on health services. These graphs are just an illustration because the time is insufficient to elaborate on what the impact really is. But we see a reduction in most services. These graphs are prepared by the Federal Ministry of Health in Islamabad. Maybe there is someone attending the seminar who has worked on the slides. So the ministry provides an analysis, a regular analysis of the situation, and we see that immunization coverage has decreased. Key maternal and child health interventions actually have decreased by up to 60%. And this disruption in essential services may result in additional maternal and child death. There has been an increase in early marriages for girls who dropped out from school, and that could result in additional adolescent pregnancies, low birth weight babies, and more children becoming stunted by the age of 2 years. Dr. Butta, whom many of you know, has done a modeling of the impact of COVID-19, not on the health services, but on mortality figures. The UN also did some modeling, so we do not know for sure what the impact will be, but what we know is that there has been a reduction in coverage of essential health services. Next slide, please. So in terms of policy challenges, there are many, and Aziz has mentioned many already. We would say that sustaining public financing will be a challenge because COVID uses up a big chunk of the public funding response to the outbreak. So there will be less to fund social services, and we risk to lose the gains that we made towards the SDGs. To build a really resilient health system, first-line health services, we have seen the importance during the outbreak. The system wasn't really able to respond to the outbreak. Hospitals were over flooded. This is not only true in Pakistan though, but Pakistan is one example where we saw the impact of a weak first-line health system. We have many community health workers, lady health workers, but the first-line clinics are not really capacitated to deal with issues that can be dealt with at primary level. And we see a focus on hospitals, and the hospitals got overflooded with COVID patients. So there was no space anymore to address, for instance, diarrhea, the priorities that children in Pakistan have. A third policy challenge is equity. We see that the better off manage to have access to services, including, for instance, immunization, and the people who are at the low end of the ladder suffer. They also suffer from lockdowns. They lost their jobs. Imagine the impact on a family where only one person earns a very minimum income. A fourth challenge is build and sustain social capital. So this is ownership, trust, accountability, how to engage the users, the community in social services. A fifth challenge, and they are not in order of importance, the health in all policies. The government of Pakistan is engaged in health in all policies, meaning that all sectors, education, well, all sectors really need to take into account health. And this will be a win-win situation because a healthy population will benefit the economical sector. Yeah, so these are 5 policy challenges that UNICEF sees that would be addressed, but it is by no means exclusive. And so, yeah, happy to discuss further if there is time. Thank you very much.
Thank you very much, Ariane. I think we must move on for the purposes of timekeeping, but I'd actually ask people if they want to put questions to you to put them in the question and answer session, and perhaps you could answer them there. So now we're going to hear from East London again. Izzy One has been involved in the critical care of patients in East London, so she's going to tell us a little bit about that. Izzy, over to you.
Thank you, Irene. I'd just like to share my slides, Pete, if you're able to stop sharing, and then I can.
Thank you.
Okay, great. Okay, so today I'll just be giving a brief insight into the impact of COVID-19 on East London, particularly from a hospital perspective, and we'll be focusing on ethnic inequalities that we found throughout our research. So as Professor Lee mentioned earlier, Barts Health NHS Trust serves a population of over 2.6 million people in East London, and we are an area with particularly high levels of ethnic diversity and also socioeconomic deprivation. And also we've experienced the highest levels of COVID-19 mortality in the UK. So on this first slide, the 2 panels on the left-hand side show numbers of patients that have been admitted across our 5 hospitals as an emergency with COVID-19 during the first wave and the second wave of the pandemic. And these are grouped by age and by ethnic group, as we can see on the x-axis and by the coloured bars. And for comparison, on the top right panel, we show numbers of emergency hospital admissions over a 6-year period before the pandemic. And then on the bottom right panel, the general population makeup in East London. And what this is demonstrating is that relative to the white population group, our local Asian and Black population groups have experienced a 2 to 4-fold higher rate of hospital admission across all age groups during the first and second wave of the pandemic. By comparison, although before the pandemic, Asian and Black patients have higher rates of hospital admission compared to white patients in general, before the pandemic, this was only about 1.1 to 1.3 times higher. And then the second slide shows survival after hospital admission. So on the left, we have a survival curve during the first wave up to 30 days after hospital admission. And the different colored lines represent different ethnic groups. So looking at the first panel on the left, we can see that in wave 1, Asian and Black patients shown by the blue and the red lines respectively, compared to white patients shown in green, have significantly lower rates of survival after being admitted to hospital with COVID-19. And this is for a patient of the same age, same sex, and also same baseline health status. Now we move on to the two plots in the middle and on the right. So apologies, the colored lines are slightly different. But looking at the middle plot, this is during the second wave of the pandemic. And during the second wave, the lower survival associated with Black ethnicity, shown in red, is similar to that for white patients, shown in blue. However, for Asian patients, shown in green, they continued to have worse survival compared to other ethnic groups during wave 2. And then finally, on the right-hand side, we followed up patients who were admitted to hospital during the first wave and looked at how their survival was 1 year after having COVID hospital admission. And this has shown that the early survival disadvantage associated with Black ethnicity has improved to around the same level as white patients. However, Asian patients continue to have worse survival even after hospital discharge. Okay. Thank you. So these are my slides. So again, if there's any questions, please feel free to ask.
Thank you very much, Izzy. And perhaps I can remind everybody to put questions in the Q&A slot, and the speakers will attempt to answer them. So we now move on to non-communicable diseases. And Professor Uzma Hassan from Pakistan is going to tell us about non-communicable diseases in Pakistan. Uzma, over to you.
Thank you very much. Assalamu alaikum and good morning to everyone. Thank you very much for inviting me as a speaker on this very important seminar on much needed important topics being discussed by very experienced and learned professionals. I'm honored to be part of your team. I will be briefly talking about the non-communicable diseases in Pakistan. We'll be touching the statistics, risk factors, impact on health, and the burden of the disease. I'll be very short because of the time constraints. Non-communicable diseases are the diseases that do not actually occur from acute infectious diseases or acute infectious process, and hence they are non-communicable in nature. A disease that has prolonged cause that does not resolve spontaneously and for which a cure is rarely achieved. These are considered as chronic diseases, and they tend to be of longer duration and it's a result of combination of genetic, physiological, environmental, and behavioral factors. And the important thing is that they touch equally to both genders, male and female. Now, a little about the WHO key fact regarding non-communicable diseases. The statistics is very much alarming. Non-communicable diseases kills 41 million people each year, which comprises 71% of all deaths globally. Each year, more than 15 million people die between the age group of 30 to 69 years of age. And this is comprising 85% of these premature deaths. And basically, a majority is from the lower and middle lower income countries. The important non-communicable diseases globally are cardiovascular diseases, cancer, respiratory diseases, diabetes mellitus. And I just want to highlight again that these 4 groups account for 80% of all the premature deaths occurring globally. Now, basically what we are going to focus is the statistics in Pakistan. NCD prevention policies in developing countries is basically a multi-dimensional challenge. Pakistan being the 6th most populous country, and the NCDs are among the top 10 causes of mortality and morbidity in our country. Pakistan basically is facing a double burden of disease. Initially, we were facing the problem with communicable diseases, but now since past 2 decades, what is happening is that the non-communicable diseases have overburdened. So now we are facing double burden of disease, non-communicable as well as communicable diseases. But to resolve this thing, first we have to emphasize on the significance that Pakistan is basically facing a major public health challenge with a devastating impact on the mortality, and economic burden. Now, what are the leading causes in, if we talk of the non-communicable diseases in Pakistan? First of all, we would like to mention diabetes mellitus, hypertension, cancers, mental disorders, respiratory disorders, arthritis, accidents, and injuries. These are the important non-communicable diseases which are prevalent in Pakistan. I would like to emphasize these are the silent killers because they threaten health without showing their symptoms. And when they are known to us, they have reached to the advanced stage. So long-term need is basically required with a personalized approach. If we see the statistics in Pakistan, it is very much alarming. Diabetes mellitus is 11% in regards of its prevalence. If we talk of breast cancer in Pakistan, it's highest in Asian population. If we talk about mental health disorders, it is covering 50% of the population of Pakistan. In regards of obesity, we can see every 4th person is obese in Pakistan. So you can see the alarming statistics in our country. If we see the projection model based on global burden of disease 2010, what do we have forecasted? We have projected that 3.87 million people will die due to premature deaths by 2025 from non-communicable diseases between the age group of 30 to 36 years of age in Pakistan. So based on these projection statistics, now what is the modeling of risk factor reduction indicating to us? They are indicating that Pakistan could achieve at least 20% reduction in the number of deaths by the year of 2025 by targeting the major risk factors related to non-communicable diseases. So we have correlated the projection, which is very much alarming. But if we work on reduction of the risk factors of non-communicable diseases, we can reduce 20% of the non-communicable diseases. Now, already Pakistan is being faced by a double burden of disease. Then there comes COVID, and the COVID has a devastating effect on the mortality, morbidity, and the economic instability of the country. Currently, more than 1.28 million infections are there from COVID, and more than 28,770 deaths from COVID in Pakistan has been occurred. And more cases are in Sindh than in Punjab, followed by KPK, and Azad Jammu Kashmir and Gilgit-Baltistan. So if we see the holistic picture, we get that Pakistan's recent socioeconomic status and the geopolitical problems have led increased prevalence of disabilities from non-communicable diseases, basically mainly the mental health disabilities. So COVID has done a big impact in regards of mental health problems being faced by Pakistani population. If we see the risk factors of non-communicable diseases, they are genetic, physiological, environmental, and behavioral. But the good thing about the non-communicable diseases is that there are 2 types of different risk factors, the modifiable risk factors and the non-modifiable risk factors. If we touch the non-modifiable risk factors in Pakistan, we can do a lot in regards of that. What are the important points which come under the modifiable risk factors in Pakistan? The tobacco use, physical inactivity, unhealthy diet, imbalanced diet, and harmful alcohol use, and as well as the stress and environment. If we come to the non-modifiable risk factors, it is in regards of age and gender, and it is touching both the gender equally. Increased blood pressure, hyperlipidemia, hyperglycemia, increased weight, and obesity. Now, touching these modifiable and non-modifiable risk factors, what we are seeing, and we can see a holistic picture that there's a poor healthcare delivery system in Pakistan. There are mixed public and private healthcare system, but they are providing suboptimal care. There are poor safety, road safety laws, which are increasing the accidents and injuries, and cheap availability of tobacco use is there because there are poor anti-smoking laws, and the food and unhealthy diet is being implemented with decreased fruits, decreased vegetables, and increased fats and unsaturated fats. Basically, what is happening, almost 3 decades of exposure of socio-political instability, economic crisis, violence, regional conflict, and dislocation are increasing the mental disorders in Pakistan, which are further deteriorating the non-communicable impact on Pakistan. Now, if we see the COVID impact on non-communicable diseases, what can we do? We have to there is a need for more investment on the health sector, especially for the diagnostic facilities, the disease surveillance, disease prevention, and disease spread. Training of health professionals is very important, but before that, I would like to say that protection of health professions, health personnel are very important, especially during the pandemic. When they are protected, then we can give them training and then they can excel in their particular domains. Pakistan, I would like to highlight over here that Pakistan is the first developing country which has a comprehensive national action plan, which is addressing communicable diseases on in good regards. There are 4 important preventive strategies which we can do in regards of non-communicable diseases in Pakistan. Number 1 is individual basis. We can work on the lifestyle modification. In the intervention regarding societal grounds, we can build or work on the awareness management. At national level, what we can do, health policy decision making. At global level, we can do health strategic planning. So most of all, to summarize, we can respect the diet, physical activities should be increased, cessation of smoking, and control of metabolic disorders. Lifestyle modification is very important to get rid of these ongoing problems. At the end, I would like to highlight the interventions on which Pakistan should really focus in regards of the increasing trend of non-communicable diseases in Pakistan. It is suggested, number 1, a functional platform for providing stewardship on NCD control is very important. Number 2, a comprehensive national NCD surveillance system should be developed, which can inform strategic planning and policy. Number 3, surveillance and research on NCDs is very important. National priority funding on Pakistan from international donors. There is a need to reprioritize their portfolios for NCD fundings in regard, we should spend more on NCDs, and increase funding for primary care is very important. 4th is multi-pronged approach by involving regulation, primary care intervention, awareness, surveillance to decrease the NCD at national scale. 5th is provincial commission for prevention and control of NCDs. It can be established as a statutory body with participation of public and private sector both to modify the risk factors for NCD. Review of health system capacity is very important. And now if we talk of the taxation and law enforcement by government, it is very important. The revenue generated by increasing the excise taxation on the sales of cigarette is very important. Sales on increasing the tax on the sales of sugary foods, junk foods, and fast food is important. So laws and challans should also be implemented on road safety to decrease the accidents. In the last being the public health professional, I would like to emphasize and conclude my talk by saying that the current focus in Pakistan is disease-oriented. It has to become health-oriented with enhanced focus on primary care, prevention, and health promotion. So primary prevention is the success and key to all the success towards the facing the heavy burden of the disease. So primary prevention programs should be prioritized at national and prevention resource allocation levels with least cost and high benefits. Thank you very much for the patient listening. If there are any questions, you can communicate through the email or you can send in the chat box. Thank you very much.
Thank you very much, Usma. And now we'll move back to London, and I'll ask Professor Walters to lead the last session from the Wolfson Institute of Population Health. Fiona, over to you.
Thank you very much. May we have the slides up again, please? And while they're arriving, I want to thank Professor Usma very much for that really important and fascinating overview of non-communicable diseases in Pakistan. There's clearly a great deal that we hope we'll be able to collaborate on. So if we bring up the slides, I'm going to move extremely rapidly through my slides. Next slide, please. And the next one, please, in order to give my two colleagues a chance to share some of their fascinating work with you. So Professor Lee has given you the context of our local population and a flavour of what the sort of work that we're doing at QMUL. I lead the Wolfson Institute of Population Health, which is an interdisciplinary collaborative, and our research focuses on improving population health and reducing health inequalities. You'll see here that we have 5 centres which are newly formed and merged and which are concentrating primarily on non-communicable disease. So we have a breadth of academic expertise. Can you go to the next slide, please? And while we do work around cardiovascular disease, for instance, we've got units in global public health, in women's health research, research on action on salt and obesity, and also on health and lifestyle, for instance, on cessation of smoking. I'd like to take us rapidly to 2 areas, one on preventable cancers and one on mental health conditions. And if we go through the next slide, please, that I won't talk about now because it's less relevant for Pakistan, and go to the next slide, please, and introduce my colleague, Professor Manchandra, to talk about the prevention of gynecological cancers.
Thank you, Fiona. And it's a privilege to be here and be part of this seminar. I'm just going to briefly touch upon some of the work we're doing in India, so relevant in the context of South Asia and thus Pakistan. So this is a program which we have been running called Suraksha. It's a South Asian breast cancer risk prediction, genetic testing, and health management program where we're working with 9 Indian centers, so cancer hospitals and medical centers across the country. And it involves 4 UK centers. That's us, Queen Mary, which we co-lead the UK part, and it's co-led in India by AIMS, Delhi, and Thisti in India. Also includes Cambridge and London School of Hygiene Tropical Medicine. The aim is to do testing for cancer genes for breast cancer patients and do case control studies to validate risk models for breast cancer risk prediction specifically for the South Asian population, and to do mainstreaming implementation science around that. We're working quite closely with community stakeholders, and a lot of the pilot and PPI work is being led by Quicksand. This has been funded by Cancer Research UK and the Department of Biotechnology in India. The next slide, please. We've helped in developing and facilitating setup of the Kolkata Gynae Oncology Trials and Translational Research Group. This is the first GCIG validated or affiliated and approved and accredited group for gynecological cancer trials in India and possibly South Asian region. So this has involved training, capacity building, doing exchange programs. It's led by Asima Mukhopadhyay, one of my colleagues, and we've had people come to QM and work with us, and there's been also people from our team going there. And it also involves joint grant applications and research projects. Next slide, please. Further, we've been doing training capacity building in terms of some short-term traveling fellowships with colleagues from India coming and spending time at QM and BARTS. We also run workshops. We started in gynae oncology training. We started the first cadaveric workshops in India. This is an association with AIMS Delhi and the Association of Gynae Oncologists in India. We also contribute to a number of the workshops, seminars, and teaching around gene testing and management of high-risk women, working closely with the Indian Society of Cancer Genetics and Tata Memorial in Mumbai and Rajiv Sarin's group there. The next slide, please. This is just an example of a multi-center collaborative which colleagues in India working with Tata Medical Center, Presidency University of Kolkata, and IIT Kharagpur were involved in, where we're looking at the potential implementation of a new paradigm for BRCA testing across populations. And this was a global analysis which we published last year. So just to give you a flavor of some of the work that we've been involved in India, I'll pass on to my colleague, Professor Baird. Thanks.
Okay, thank you. If I get the next slide, please. So I'm going to talk a little bit about some of the work that we've been doing in terms of mental health. We've had a number of completed ongoing studies and also our future plans. And one of the key features of all of these is that we're aiming to improve quality of life for people with mental health problems, particularly those individuals who have long-term conditions such as chronic psychosis or long-term depression. And we're trying to use innovative methods such as e-technology and digital technology, and also mobile mental health that takes mental health to the community, so that we can come up with solutions that take mental health out of the hospital and place it back in the community and make this a priority. So we recently completed a study where we were able to do some task shifting, and we trained lay counsellors who actually work in TB, and this was conducted in Karachi. We trained lay counsellors to be able to detect depression and anxiety, and then to use a solution-focused approach with individuals to improve their quality of life. And next slide, please. What I'm going to focus on mainly is the large project that we have running at the moment, sponsored by the NIHR, which is looking at improving the community-based treatment for people with long-term psychosis. And this is being conducted in India and Pakistan, and includes a range of partners, notably from Pakistan, Aga Khan University and Interactive Research and Development, who are a private non-for-profit company who work in and around the region for research, particularly on public health. Next slide, please. So what makes PIECES unique is that we're trying to move treatment out of the hospitals and into the community. And we're trying to come up with solutions to empower individuals so they can manage and self-manage their own condition. And this is obviously alongside working with clinicians and families. But two of the key features that I just wanted to note that are common in all our work is that we're trying to give voice to people with psychosis. This has been raised as a real issue, that people with psychosis are often left out of the dialogue about their care. So both in India and Pakistan, we've set up some of the first lived experience advisory panels. And here we have a group meeting in Pakistan where we had about 8 or 9 members, all with lived experience of psychosis, or their carers, who came together to come up with solutions to issues faced in their care. And next slide, please. And the other feature that we're using that's really unique to this particular project is to involve the local community. And we're doing this via arts projects. And in particular, we're running Theatre of the Oppressed, which makes use of forum theatre to get the audience involved. So we are working on the power dynamics between patients and carers, between people with psychosis and the rest of the community, and between people with psychosis and the health professionals. And next slide, please. Obviously, this was all affected by the pandemic, but I'm pleased to say here we have an example of a theatre production that we ran in Karachi in Pakistan with healthcare workers, which explored the power dynamics between when a patient to a coming in for hospital treatment. And we're using art to try and break down those barriers in the community. And in fact, it's been so successful that we're now putting in another grant to strengthen this work and to really focus on, well, how can we involve community in community-based care? Next slide, please. And just to finish, because this has been a very whistle-stop tour, that was part of our forum theatre as well. Just a whistle-stop tour. So I've added the website. We have a very interactive and very sort of active website and newsletter. So if you're interested in the Pizzas projects, I'm always more than happy. It's a bit of my my baby, really, this one. So I'm always more than happy to talk about it because it really is having an impact. And we're just about to start our big trial of around 400 people in both India and Pakistan. So there's some exciting updates coming out at the moment. But our main impact so far has been that we've got the community talking about mental health. Mental health is something that's all of our problem and all of our concern. And that's what we're trying to address in this particular project. Thank you.
Thank you very much, everybody. And I'm really sorry that with the late delay in starting, we have not had enough time to ask questions. But I'd like to finish by posing a question from the chat for Mr. Menon, which is quite relevant, I think, to the recent discussion, which is about what is the role of primary care in the management of non-communicable diseases in Pakistan. Aziz, would you be able to answer that? Or perhaps we can take that offline, and I'll hand over to Professor Grant for his final remarks.
Professor Lee, Irene, thank you so much, and what a simply outstanding session. I'm really very moved by the presentations. We've had incredible depth of insight, undaunted by the scale of the challenge, and for me, an abiding sense that we can make common cause and are already making common cause. But let's do more in using evidence to drive policy and social impact. And please join us in our new coalition, the Resilient Futures Pakistan Initiative. I'd like to salute all of our panelists who are doing so much on the front line. And I salute you, our audience, for your quite exceptional engagement this morning, this afternoon. Thank you also to our technical team for dealing with adversity. Keep in touch and join us. Shukriya. Thank you very much indeed.
Professor Colin, can I give some remarks?
By all means, Aziz, please.
I wanted to thank you. And with the exception of some hiccups in the beginning, it went on very well. Just now I was talking to the coordinator of English Speaking Union and our life member, Afshan Lalani, who did the whole coordination and worked very hard. She said that she didn't get the link to join, and all the staff of Queen's got it and they were visible and she was not. So I thought I'll convey her remarks to you also, so that in future, if we do it, we can take care of that. And I'll convey to Afshan that her feelings have been conveyed.
Absolutely. Thank you very much for sharing that, Aziz. There's very much a spirit of partnership and mutual learning, and there's a learning point for us there. Thank you very much indeed. Irene, back to you.
No, thank you very much. I'm sure that we'll want to follow this up with detailed collaborations, and the recording of this seminar will, I hope, be available to those people who haven't been able to join us in person to extend the range. So have a good morning, good afternoon, and we'll see you again.
Thank you.
Thank you, everyone.
Thank you very much. Thank you, everyone.
Thank you, Prof. Usman.